Today we are going to see around 30 questions from different systems of physiology. Let's start with the CNS physiology. Here is the first question. Sharp pain is transmitted by which type of fibers? So pain is an area now it's gaining more importance. So you will get many questions from this area. So let's start with pain first. Sharp pain is transmitted by which type of fibers? Option A alpha. Option B, A beta. Option C, A delta. Option D, C fibers. So we know that there are two types of pains. Sharp pain or fast pain. Second one is slow pain or diffuse pain from the visceral organs. Diffuse pain from visceral organs. So the receptors for pain, every pathway starts from a receptor. Right. The receptor for pain is known as nociceptors. Nociceptor. Here it is the free nerve endings. Free nerve endings. And in case of sharp pain, the sensory information is transmitted through A delta fibers. The answer for this question is A delta fibers. Sharp pain is from this A delta fibers finally terminate in which part of the spinal cord? Lamina 1 of spinal cord. Here is the lamina 1 of spinal cord. From the lamina 1, the second order neuron originates. In the pathway, we have first order neurons, second order neurons, and third order neurons. Here, it terminates in the lamina 1. So, which is the neurotransmitter? It's another important MCQ. Glutamate. In case of sharp pain, glutamate is the another MCQ. Glutamate is the neurotransmitter here. From the lamina 1, it actually crosses to the opposite side and ascend as lateral spinothalamic tract. And this pathway for the sharp pain, it is known as neo-spinothalamic pathway. For pain, it is sharp pain, it is neo-spinothalamic tract. And this one finally goes to the thalamus. Thalamus is the relay center for many sensations, which is the nucleus. Ventro-posterolateral nucleus of the thalamus, VPL, ventro-posterolateral nucleus of the thalamus, which is very important. From here, so there are two nucleus, ventro-posterolateral and ventro-posteromedial. The medial is for sensations from the face. This is another MCQ. Pain sensation from the face actually terminate in the medial nucleus, ventro-posteromedial, while the pain sensation from all other parts of the body terminate which nucleus of the thalamus? It is ventro-posterolateral nucleus of the thalamus. And the thalamus, from the thalamus, another important point is it helps the localization of the pain. Localization of pain occur at the level of thalamus, not at the level of cerebral cortex, which occur at the level of thalamus. From the thalamus, it goes to the somatosensory area of the brain. So this is the pathway of the neospinothalamic tract or the pain pathway of sharp pain. So here, C fibers. What about the C fibers? C fibers actually carry slow pain. slow pain or diffuse pain. Especially these fibers carry from the pain from the abdomen or visceral or any visceral part, which is poorly localized, which is the diffuse kind of pain, which terminate in two other laminas of the dorsal horn of spinal cord, lamina 2 and 3. Here, lamina 2 is very important. Lamina 2 is also known as, it is the gate. It is important. We will discuss it while we discuss the gate control theory of pain. Gate is located in which lamina? Another MCQ. It is located in the lamina 2 of spinal cord. It is also known as substantia gelatinosa of Rolando. It's important. It's another important MCQ. Substantia gelatinosa of Rolando is the gate. From here, the neurotransmitter is different. It is substance P. For diffuse pain, it is substance P more than this glutamate. This is substance P. From here, it terminates to lamina 5 and then goes to three different areas of the brain. In the midbrain region, the paleo-spinothalamic tract, this tract is known as paleo-spinothalamic tract. For the diffuse pain, it is paleo-spinothalamic tract. It goes to three different areas. First one, reticular nucleus. We know that the reticular activating system or reticular nucleus is concerned with arousal. So the pain causes arousal. Reticular and tectal nucleus both are related to arousal and sleep. So this one causes arousal, the pain causes arousal. And another region is periaqueductal gray. These are the regions. So 90% of the paleo-spinothalamic tract fibers goes to here. These regions. Only 10% goes to the thalamus. That's why it is poorly localized. Thalamus is the region which helps to localize the pain. That is why the visceral pain is poorly localized. And finally, these fibers goes to somatosensory area of the brain. Next question. This is also related to pain. Pain relief in acupuncture is mediated by. So this question directly relates with the gate control theory of pain. Option A, endogenous opioids. Option B, kinins. Option C, substance P. Option D, prostaglandins. So pain relief in acupuncture or applying any liniments or rubbing. What is happening? So this could be explained by a theory known as gate control theory of pain. So in the previous slide, I mentioned that the gate is located here. This is the gate, lamina 2 of the dorsal horn of spinal cord. And it was proposed by two scientists, Melsack and Watt. So here is the gate. So let's try to understand what happens in this when we apply liniment or acupuncture. So this is the fiber, pain fiber. It could be a delta in case of fast pain. It could be C in the case of slow pain. So which carries pain to the spinal cord. So we are applying some liniments or rubbing that can activate another fiber, A beta fiber, which carries touch sensation. A beta for touch sensation. And this fiber, this A beta fiber could activate one interneuron. This is the interneuron. This black one is the interneuron. This interneuron is an encephalinergic neuron. Enkephalin means it is the endogenous opioid. We know that opioids are important in pain relief. So it is an endogenous opioid. Enkephalin. This encephalinergic neuron secrete enkephalin, and which is going to inhibit this A delta fibers presynaptically, as well as the second order neuron is also inhibited. So this is the gate where we can see this encephalinergic neurons which inhibit pain fibers. This is what happens in case of acupuncture. I hope it is clear. So this enkephalin is also important. Enkephalin is an endogenous opioid. So in this question, the answer will be, which is the answer? Endogenous opioid. Enkephalin. Pain relief in acupuncture is mediated by enkephalin, which is an endogenous opioid. These are endogenous opioids, enkephalins, endorphin and dynorphin. These are endogenous opioids. Exogenous opioid is morphine. Next question is, Raphe nuclei located in the lower pons and medulla secrete which of the following neurotransmitter? So this question is related to modulation of pain. Modulation means it is changing or decreasing pain. Option A, norepinephrine. Option B, dopamine. Option C, serotonin. Option D, acetylcholine. So, which is the correct answer? Raphe nuclei in the lower pons. So, pain modulation occur at two levels. One level is at brain. It can occur at the level of brain. It can occur at the level of spinal cord. Spinal cord, we have already discussed, it is the gate control theory or gate. In the brain, it is especially seen in the midbrain region and brainstem. These are the parts of brainstem, pons and medulla. So there are regions, it is periventricular gray and periaqueductal gray, which is seen in the midbrain and upper pons. From these regions, here you can see the blue lines are the neurons arising from this periventricular gray and periaqueductal gray region of the midbrain and upper pons. These neurons are encephalinergic. We have already seen encephalinergic neurons are the endogenous opioids, encephalinergic neurons. These neurons finally goes and terminate here. Midline Raphe magnus. This is our question. Midline Raphe magnus nucleus, which is in the lower pons or the upper medulla. These encephalinergic neurons terminate. And these neurons also terminate in locus ceruleus. From the midline Raphe magnus nucleus, another neurons are arising. This pathway is serotonergic pathway. So that means this secrete serotonin. So which is a neurotransmitter coming from this Raphe magnus nucleus? It is nothing but a serotonin. From the locus ceruleus, it is noradrenaline. And this can activate, these two actually inhibit our A delta fibers through activating this encephalinergic neurons, interneurons. So this is known as supraspinal control or or brain analgesia system. Brain analgesic system. So the midline raphe secrete serotonin, locus coeruleus secrete noradrenergic, which can inhibit this A delta fibers. So here the answer of our question is raphe nucleus located in the lower pons and medulla secretes serotonin. Serotonin-ergic neurons are coming from this nucleus. Which of the sensory receptor found in epidermis? We have Merkel's disc, Meissner's corpuscles, Ruffini ending, and Puccinian corpuscles. These are sensory receptors present in our somatosensory receptors present in our skin. Let's try to understand their location. These are the sensory receptors. So all the receptors present in dermis except one, except Merkel's disc. Merkel's disc is a disc-like thing which is presented here, where it is in the epidermis. So the only one present in the epidermis is Merkel's disc. Merkel's disc. So here this onion peel appearance is onion skin appearance is for Puccinian corpuscle. We have this blue one is Ruffini endings. Meissner's corpuscles. Meissner's corpuscles also seen in the upper part of the dermis, not in the epidermis. Only Merkel's disc present in the epidermis. So it's very important. This is the answer of our question. Let's try to see some important aspects of important points regarding these receptors, somatosensory receptors. The touch receptors, we can classify them as rapidly adapting and slowly adapting. Puccinian corpuscles, Meissner's corpuscle, hair and organ, these are coming under rapidly adapting receptors. Merkel's disc, Ruffini endings, free nerve endings are coming under slowly adapting receptors. So here, Puccinian corpuscle, it is the largest receptor, largest somatosensory receptor, and the most sensitive. It is the most sensitive one, and which is the best stimulus or stimuli. Best stimuli is high frequency vibration. High frequency vibration. Vibration more than 400 hertz. So these are the three important points. It is the largest one and most sensitive receptor, and the best stimulus is high frequency vibration. Next one, Meissner's corpuscle. Meissner's corpuscle is the most abundant. It is the most abundant sensory receptor. Most abundant sensory receptor. And it is another M for this is it sends best stimulus is movement. It is a movement receptor. It's a movement receptor. And it can sense vibrations, but low frequency vibration, less than 50 hertz. Low frequency, it can sense very low frequency vibrations. Hair and organ is a non-specific. It is a non-specific receptor. Merkel's disc, we have already seen, it is only epidermal, only receptor seen in the epidermis, and it is known. It appears as a dome-like projection, so it is known as IGO. IGO is the scientist discovered this IGO dome receptor. IGO dome receptor. Merkel's disc. So it can the most or the best stimulus best stimuli are the points or edges, corners. So these are the best stimuli. So which is the ego-dome receptor, that is Merkel's test. So it is a very important question. Very important. Pacinian corpuscle is also another important receptor. And Ruffini endings, it respond to stretch of the skin. Stretch of the skin, it can identify size and shape of, it respond to stretch of the skin. And it can identify shape and size of handheld object. Handheld object. Pre-nerve endings actually receptors for itch and tickle. These are the important points regarding touch receptors. Fine touch and position sense is carried by, which is the pathway for fine touch and position sense? It's an easy question. So, androlateral system or androspinal thalamic tract, which is for crude touch and pressure. Crude touch and pressure. Lateral spinal thalamic, which are the sensations carried through lateral spinal thalamic tract? It is pain and temperature. These are pain and temperature. And it is the sinus-cerebellar tract is for the tract for cerebellum, and here the dorsal column. Dorsal column, it is the fine touch, joint position sense, vibration sense, proprioception. So fine touch. The answer here is the D, option D, dorsal column. Fine touch and position sense is carried. These are carried by dorsal column pathway. So this is the androlateral pathway. Itch and tickle is also transmitted through this lateral pathway. It's important. Itch and tickle is carried through which pathway? Lateral spinothalamic tract. Please note this. Itch and tickle. And the dorsal column medial lemniscal system is also known as pathway of Wallenberg. Fine touch, joint position sense, vibration sense, proprioception. These are the sensations carried through pathway of Wallenberg. This is a question related to EEG and sleep. Theta waves are seen in stage. Option A, stage 1, option B, stage 2, option 3, stage, option C, stage 3, option D, stage 4. So EEG. EEG means it is electrical. It is a recording of the electrical activity of the brain by putting surface electrodes on the surface of the scalp. From in the order of decreasing frequency, we can write the waves. The code is bat dance. Bat dance means decreasing order of frequency. So beta waves having maximum frequency and decreased amplitude. Then alpha waves. Then we have theta waves and delta waves. Delta waves, theta waves and delta waves. Now let's see the important features of these waves. Beta waves. When we get these beta waves are seen in when our eyes are open, when we are alert, we are reading something, concentrating on something, writing something. So when we are alert, so our brain activity is very high. So we will get a high frequency waves like this. These are beta waves. So beta waves are actually coming from the frontal region of the brain. These are beta waves, and we will get these beta waves when I'm awake, alert, eyes open, focusing and concentrating from the frontal region. Then next wave is alpha waves. Alpha wave. Alpha waves, we get alpha waves when our eyes are closed, when our mind wandering. Eyes are closed and mind wandering. Frequency is less than beta. So alpha waves we get relaxed, eyes closed, mind wandering. So in case of beta waves, it is coming from the front, but in case of alpha waves, it's from the back, from the occipital region. And one important point, to produce alpha wave, diffuse thalamocortical projection from the thalamus to cortex is essential for the production of alpha waves. And next, this is alpha block. A sensory stimulus can awake or arouse the person. So his alpha waves, initially the person was as wandering, wandering or his eyes closed. Suddenly a sensory stimulus, this could awake the person. So here the eyes open. So here is the eyes closed. So suddenly there is a change of alpha waves to beta waves, an increased frequency, low amplitude waves. This is known as alpha block. The alpha waves are blocked by the presence of a sensory stimulus. This is known as alpha block. Next is theta waves. Theta waves. Theta waves and delta waves both are high amplitude waves, low frequency, high amplitude waves. Important features of theta waves. Theta is mainly seen in children. It is normal in children. Normal in children. And it is also seen lighter stages of sleep. Lighter stages of sleep means NREM 1. NREM 1. Lighter stages of sleep. And also its location is parieto-temporal, middle part, parieto-temporal, and it is seen in depression and degenerative brain disorders. So it is seen in depression, and these points are very important. These are MCQs, which is a wave seen in depression or the brain degenerative disorders. Pathologically, it is seen in degenerative disorders. Theta waves, they are high amplitude or waves, low frequency waves, normal in children. Delta waves. Delta waves having maximum amplitude. They have having maximum amplitude, low frequency. They are known as slow waves. They are seen in slow wave sleep or NREM stage 3 and 4. Deep sleep stages, slow waves. Deep sleep or surgical anesthesia and organic brain disorders. Here, thalamocortical connection is not essential for the production of delta waves. These are important points regarding delta waves. Their maximum magnitude or maximum amplitude for these waves. Next, we will see the important stages of sleep. Important stages of sleep means this is a sleep cycle. It's a representation of sleep cycle, which starts from NREM stage 1, NREM stage 2, NREM stage 2, stage 3, stage 4, and REM sleep. So this is a lighter form of sleep. Here it becomes deep sleep. Normal duration of a sleep cycle is around 90 minutes. 90 minutes. There is a newer classification. Here, there is a newer classification. That means NREM is again classified into first one, N1, N2, and N3 include both the stages, N3 and NREM 1 and NREM 3 and NREM 4. NREM 3 and 4 include in the stage N3. And REM is represented as R stage. This is the recent classification of sleep. This is a sleep cycle. N1, N2, and N3. N3 include NREM stage 3 and 4. And R is the last stage, REM sleep. This is represented by a hypnogram. The features of NREM 1, it is a very light stage. And here you get the theta waves. Stage 2 is also a light stage. Stage 3 and 4, moderate to deep stage. So, which are the EEG waves in different stages of sleep? In stage 1, this is the answer of our question. Theta waves are seen in NREM stage 1. NREM stage 1. And stage 2 is important. In stage 2, we get sleep spindles and K complexes. Very important. This has been asked for many exams. K complexes are seen in which stage of sleep? It is NREM stage 2. NREM K complex. K complexes are actually high voltage biphasic. Can you appreciate this? This has two phases, biphasic. And here you can see spindle-like waves. These are known as sleep spindles. So both are the features of NREM 2 sleep. Sleep spindles and K complex. Right. And the stage 3 and stage 4, both are stages of deep sleep. So we have to get large amplitude waves, delta waves. So stage 1, so let's recollect. In the stage 1 we get theta waves. Stage 2, sleep spindles and sleep spindles and K complexes. Stage 3 and 4, we get the 3 and 4, we get delta waves. So this is very important. And about REM sleep, in case of REM sleep, it is also known as paradoxical sleep. Why is it called as paradoxical sleep? It is a deep sleep, but the EEG, when we take the EEG of the person, the EEG actually shows brain activity like beta waves. Beta waves, we know that it is conscious alert state. We get beta waves in a conscious alert state, eyes open. But these kinds of waves can also seen in REM stage of sleep. That's why it is a paradox here. So that's why it is known as paradoxical sleep. So very important. Please note this point. It is a paradoxical sleep. In REM sleep, we get beta-like activity. This is another important point, another important MCQ. PGO spikes. PGO stands for pondogeniculo-occipital waves. These are phasic waves originated from the pons. The name itself shows that it originates from the pons, cholinergic neurons of the pons. It is important in consolidation of memory. So we get PGO spikes in which stage of sleep? It is REM sleep. REM sleep, we get PGO spikes. PGO spikes are some kind of waves. Waves arising from the pons, phasic waves arising from the pons. We get it in REM sleep. What is the significance of these waves? It involves in consolidation of memory. So it's another MCQ. Consolidation of memory occur in which stage of sleep? Answer is REM sleep. So we have discussed many MCQs. So very important. EEG and sleep is a very important and interesting area. You get maximum number of MCQs from this area. Motor supply of muscle spindle. Now we will see the motor aspect of the central nervous system. Motor supply of muscle spindle. So what is a muscle spindle? It is a receptor for which reflex? It is a receptor for stretch reflex. It is a receptor for stretch reflex, which is a receptor for inverse stretch reflex. It is Golgi tendon organ. So here the muscle spindle is a receptor for stretch reflex. What is a stretch reflex? When we stretch a muscle, it will respond by contraction. That is stretch receptor reflex. What is an example of stretch reflex? It's knee jerk. Knee jerk. When we strike the our patellar tendon with our knee hammer, it responds. We will get a jerk. So knee jerk is a stretch reflex. It is a monosynaptic. It is an example of monosynaptic reflex. It is a monosynaptic reflex. That means only one synapse occur in this pathway. So it occur at the level of spinal cord. This reflex never goes to the brain. It reflex occur at the level of spinal cord. Spinal cord, and it is a monosynaptic reflex. So this is the muscle spindle, which is the receptor for muscle spindle is the receptor for stretch reflex. It has mainly two parts. One contractile region at the end, or it is inserted inside the fibers known as, these fibers are known as extrafusal muscle fibers. Note this point, extrafusal fibers are contractile portions which are the contractile elements. We have actin and myosin. It has actin and myosin, contractile region. The extrafusal. The intrafusal fiber is as the sensory receptor or stretch receptor is intrafusal fibers. Which are the parts of intrafusal fibers? Let's try to understand the intrafusal fibers. The muscle spindle which contain which contain nuclear bag fiber and nuclear. Here you can see a bulged area and so many nucleus. It is the nuclear bag fiber. Here it is the nuclear chain fiber. This is intrafusal. These are the parts of intrafusal fibers of the muscle spindle. And this is the stretch reflex. So muscle spindle, when we stretch or strike the tendon with the knee hammer, what will happen here? The muscle spindle sense this, and the sensation is carried to the spinal cord through sensory nerves. Here is the spinal cord, here is the dorsal horn, and here it is the motor neuron supply. These are the afferent, and efferent is through the motor neuron, alpha motor neuron. But this alpha motor neuron is not going to the muscle spindle. It actually goes to the extrafusal fiber. Muscle has to contract in response to the stretch. So it goes to extrafusal fibers. So it is a very important point. We must understand that this alpha motor neuron, which is supplying to the muscle, which actually goes to the extrafusal fibers, not to the intrafusal fibers. So this extrafusal muscle, since it contains actin and myosin, it will contract. So stretching is sensed by the muscle spindle, which is carried through the sensory afferent, but the efferent is through the alpha motor neuron, which is to the extrafusal fiber, it will contract. So which are the sensory afferents? Sensory afferents are 1A, it is known as the primary afferent, and 2 is the secondary afferent. So this is the sensory afferent fibers or sensory connections. 1A primary afferent, 2 is the secondary afferent. And here the efferent is alpha motor neuron. Then what is the role of gamma motor neuron? Gamma motor neuron is the efferent supplied to the efferent supplied to the muscle spindle. It is gamma motor neuron which actually alter the sensitivity of muscle spindle to stretch. Alter the sensitivity to muscle spindle. So gamma motor neuron is the efferent connection to muscle spindle. Alpha motor neuron, it is to the contractile elements. So answer of our question is gamma motor neuron. Motor supply to the muscle spindle is through gamma motor neuron. 1A and 2 are afferents. So these are the annulospiral endings of the afferent fibers. 1A fiber and 2 are the afferents, and this through the gamma efferent. Here you can see plate endings and trail endings of the gamma efferent. Next is blood-brain barrier is present all of the following except. Blood-brain barrier is present in all of the following sites. So blood-brain barrier, option A, habenular nucleus, option B, subfornical organ, option C, cerebellum, option D, Pontine nucleus. So there is a barrier, a protective barrier exists between the brain and the capillaries or blood vessels. So it is formed by the tight junctions of endothelial cells. These are the endothelial linings of the capillaries, the tight junctions. And it is surrounded by the astrocytes, food process of the astrocytes. These two together form blood-brain barrier. So only few substances like water, lipid soluble carbon dioxide, oxygen, these particles can cross the blood-brain barrier. And some steroid drugs also, since they are soluble in lipids, steroid drugs can cross the blood-brain barrier. But the ions, not this ions, hydrogen ions, bicarbonate ions, and dopamine, this cannot cross the blood-brain barrier. That is a problem. And some areas which do not have this blood-brain barrier, they are outside the blood-brain barrier. These are known as neurohemal areas. Neurohemal. This is the astrocyte. Here you can see the astrocytes and the tight junctions. Circumventricular. These organs are known as circumventricular organs. Small areas outside the, there are all 4 areas outside the blood-brain barrier. So you have to by heart these areas. So the easy way to by heart this, the code is MOPS. So M for median eminence of hypothalamus. Median eminence of hypothalamus. M for median eminence of hypothalamus. O for OVLT, organum vasculosum lamina terminalis. P for posterior pituitary, and area postrema. S for subfornical organ. So MOPS. Median eminence of hypothalamus, OVLT, posterior pituitary and area postrema, and S for subfornical organ. So answer of our question. Let's go back and see the question. Blood-brain barrier is present at all of the following except answer is option B, subfornical organ. Next, we will see questions from endocrine and reproductive physiology. Which is not a peptide hormone. Peptide hormone. So we have different hormones which are secreted from the endocrine glands to blood. So these hormones could be amine type, amino acids, amines. And most of the hormones are peptide and proteins, small peptides and proteins. Some others are, a few hormones are steroid and vitamins. Let's see which are the hormones, which are the, an important point regarding the amines and peptides. Amines and peptide hormones, they are water soluble, so that they cannot cross the lipid layer of the cell membrane. So they act on the surface. Suppose this is a cell. They act on the surface of the cell, surface receptors. They can act on the G protein coupled receptor and any other receptors. So surface, but they cannot cross this the cell membrane. So they act on the surface of the amines and peptides and these proteins act only on the surface. But here in the nucleus, the steroid hormones and vitamins, they can cross this lipid layer and act on the nuclear. So these are having nuclear receptors. That's the basic difference. Why these amines and peptides act on this cell surface. At the same time, this could act on the nucleus, but because they are soluble in lipids, they can enter into the cell and act on the nucleus and increase the nucleic acid synthesis. So let's see which are the different hormones. Here is a classification of hormones. So amino acids or amide derivatives, which include catecholamines. The name itself shows that it is a the catecholamine hormones these are amino acid derivatives. Thyroxine, from the amino acid tyrosine, triiodothyronine or tetraiodothyronine, serotonin, melatonin, histamine. These are amino acid derivatives. And then peptide hormones, all the hypothalamic hormones, all the anterior and posterior pituitary hormones, pancreatic, parathyroid, calcitonin, erythropoietin, from the gastrin, from the stomachs, many hormones from the stomach, gastrin, CCK, secretin, and from the placenta, HCG, human somatomammotropin, renin-angiotensin. Most of the hormones are proteins and polypeptide hormones. Which are the steroid hormones? These are important. These are mineralocorticoids from the adrenals, glucocorticoids, mineralocorticoids, just sex steroids, like testosterone, estrogen, and progesterone. These are the hormones released from the adrenals. And vitamin derivatives, vitamin D and vitamin A. So let's see our question. Which is not a peptide hormone. Answer is serotonin. Somatostatin, neuropeptide Y, enkephalin. These are peptide hormones. Serotonin is an amine. Which hormone act on JAK-STAT receptor? JAK-STAT pathway. So hormone, this is important. There are 4 hormones act through JAK-STAT pathway. So you have to by heart study these four hormones. It's an important MCQ. Growth hormone. Growth hormone acts through JAK-STAT pathway. Prolactin, erythropoietin, leptin. These are the hormones act through JAK-STAT pathway. So let's see what is its JAK-STAT pathway. So whenever a hormone acts on this receptor, leptin or any other hormone act on this receptor, this could activate, or this can, it's a protein kinase, Janus kinase, phosphorylate, adding a phosphate unit here. Janus kinase. This Janus kinase can again phosphorylate STATs. STATs means signal transducer and activator of transcription. So these are activators. STATs are activators of transcription. Whenever the STATs are activated, they can directly activate the genes for transcription. So this is JAK-STAT pathway. First, initially, the binding of hormone with the receptor could activate this Janus kinase or phosphorylate this one. This again phosphorylates STATs, another type of proteins. The STATs, full form of STAT means signal transducer and activators of transcription. You have to remember only these four names of these four hormones: growth hormone, prolactin, erythropoietin, and leptin. It's a very important question. All types of cells are present in anterior pituitary, except all types of cells present in anterior pituitary. So anterior pituitary, 5 types of cells present, and which release 6 types of hormone. Which are the 5 types of cells? Somatotrope. Somatotrope actually release which hormone? Growth hormone. Thyrotrope. TSH. Release TSH. Gonadotropes FSH and LH. And lactotrope prolactin. And corticotrope release ACTH. So these are this somatotrope and lactotrope are acidophilic. The other hormones are basophilic. Growth hormone has its effect on growth. So growth hormone is an important hormone from the anterior pituitary. We know that it acts through JAK-STAT pathway. It's a very important thing, JAK-STAT pathway. And its effects, it acts through, it can directly, what are the physiological effects? Or the physiological effects are mediated by insulin-like growth factor 1. So it can act directly, and it can act through insulin-like growth factor 1. So the direct actions are mainly metabolic effects. Direct actions are metabolic effects. What are the metabolic effects? Effects on the glucose or carbohydrate metabolism. It will increase the level of glucose, or it has an anti-insulin effect. Anti-insulin effect. And it can increase the gluconeogenesis, and decrease the peripheral conversion of glucose. Gluconeogenesis increase. Then it decrease the peripheral conversion. Finally, it will increase the glucose level. It has a diabetogenic effect, or increase the glucose level. We need more glucose for growth. So here the glucose level is increased for more carbohydrates, for energy production. In the case of lipids, it promotes lipolysis. Breakdown, increase the activity of hormone sensitive lipase. And it will finally increase the lipolysis. In the adipose tissue, it will activate the hormone sensitive lipase, which convert the lipids to fatty acids and glycerols. And in case of protein, it is anabolic, protein synthesis. For growth, protein synthesis is essential. So it is an anabolic. So the metabolic effects are the direct action. It is through the direct action. But indirect action, it is by the growth promoting actions or the growth of bone and growth of cartilage, formation of osteoblast cells and cartilages. These are mediated by insulin-like growth factors. One important point, these are produced from the liver. These are also known as somatomedins. These are the important points. And the regarding the growth hormone, and one dwarfism is associated with the growth hormone, Laron dwarfism. Laron dwarfism is due to insulin receptor insensitivity. What is the cause of Laron dwarfism? And it is it is the growth hormone receptor insensitivity. Growth hormone receptor insensitivity. Cause for Laron dwarfism is growth hormone receptor insensitivity. And the growth hormone peaks. It shows a circadian pattern, and it peaks. Its level peaks after deep sleep. During deep sleep, highest peak first few hours of sleep. So its secretion, it follows a circadian rhythm, and its highest peak in first few hours of sleep. So these are the indirect actions: epiphyseal growth, deposition of chondrogen sulfate. This is an indirect action. Direct action, it favors lipolysis, but indirectly it is anti-lipolytic lipolysis, protein synthesis, and insulin-like activity. So these are opposite. These are opposites of direct action. Direct action, in case of direct action, it favors lipolysis. In indirect action, through insulin-like growth factors, it actually stimulates lipolysis. It is anti-lipolysis, and it is in direct action. It is anti-insulin. Here it is insulin-like activity. Indirect. ACTH levels is higher during early morning, evening, afternoon, and night. It is in the early morning. The answer is early morning. So the ACTH also shows some circadian pattern of release. High in the early morning, it is low in the evening. So 75% of daily secretion occur between 4 a.m. and 10 a.m. in the early morning, peaks at 6 to 8 a.m. So ACTH secretion is maximum in the early morning, 6 a.m. to 8 a.m. It is lowest in the evening. Glucose-mediated insulin release is mediated through. So we know that glucose is the most important stimulus, most potent stimulus for insulin release. So insulin is released from from here. It is the beta cell. Insulin is stored inside the beta cell in the vesicle. You can see here the insulin is stored. So here is the glucose transporter. So this is important. Which is the glucose transporter in the beta cell? It is GLUT2, glucose transporter 2. In case of muscle and adipose tissue, it is muscle and adipose tissue, GLUT4 for the muscle and adipose tissue. It's another important MCQ. So once the glucose enter into the cell, the glucose undergo glycolysis to produce what is the end product of glycolysis? ATP. So there is a channel known as ATP sensitive potassium channel. Here is a channel, ATP sensitive potassium channel. So usually from this, since potassium is a most important intracellular cation, it goes out of the cell. It is a normal condition. Normally it moves out of the cell. It is this channel is very sensitive for ATP. So when the level of ATP increases, here by the glycolysis, the level of ATP inside the cell increases. So whenever the level increases, it can block this channel. ATP level increases, this channel is permanent. It's blocked. That will lead to a rise in potassium inside the cell. That means usually inside the cell is negative. Here the positive charges are going to accumulate here, which lead to reversal of polarity, depolarization of the cell. Depolarization means increase positive charge inside the cell. That will lead to opening of another channels, calcium channels, through which the calcium enters. It is just like the neurotransmitter release. The calcium enters, the neurotransmitter is released. Like this, insulin is released. So here the answer of this question is glucose mediated insulin release is mediated through ATP dependent potassium channels. Regarding thyroid hormone, all are true except T3, option A, T3 is more avidly bound to nuclear receptor than T4. T4 has maximum plasma concentration. Option C, T3 is more active than T4. Option D, T4 has shorter half-life than T3. So these are the two thyroid hormones from the thyroid, T3 and T4. Triiodothyronine and tetraiodothyronine. So the tetraiodothyronine, the peripheral conversion of tetraiodothyronine to triiodothyronine by 5-deiodinase. It is an enzyme. 5-1 iodine is removed. Deiodinase, which would convert T4 to T3. So T4 is the most abundant thyroid hormone, T4. But the most of the metabolic effects of thyroid hormone is mediated by T3. It is very fast. And T3 is more, which is more active? T3 is more active than T4. And T3 is more avidly bind to nuclear receptor. We know that the thyroid hormone is acting through nuclear receptors. So T3 more avidly bind with the nuclear receptor than T4. When it is metabolically active, more active than T4, but the maximum plasma concentration is for T4. And it is converted to T3 peripherally. That is a peripheral conversion by deiodinase. So maximum plasma concentration is for T4. And the half-life of T4 is 6 days, while there's a T3 has less half-life, 1 day, only 1 day. And the T4 is bound with the albumin, strongly bound with albumin, and it cannot induce a transcription. Only T3 can bind with the nuclear receptor and activate transcription. So let's see the first option. T3 is more avidly bound to nuclear receptor. T3 is the active one. It is more avidly bound to nuclear receptor than T4, which is the correct. This is the correct option. T4 has maximum plasma concentration. This is also true. T4 has maximum plasma concentration, which is converted into T3. And T3 is more active than T4, which is also correct. T3 is more active than T4. It acts then, which mediate all the metabolic effects. And T4 has shorter half-life than T3. This is the wrong answer. T4 has shorter half-life than T3 is wrong. T3 has shorter half-life than T4. T3 half-life is 1 day. T4 6 days. Wolff-Chaikoff effect is due to option A, suppression of TSH secretion. Option B, decreased iodinization of monoiodothyronine. Decreased T3 conversion, T3 to T4 conversion. Excess iodine affect organification of iodide. Here the suppression of TSH action. Here the answer is It's a excess iodine. So excess iodinization. So use of iodized salt is not beneficial for the thyroid. It finally lead to decreased secretion of T3 and T4. So here this excess iodine will affect organification of iodide. That is the correct answer. Organification of iodide. Organification means the combination of iodide with the tyrosine residues, that is known as organification. So to understand this answer of this question, first we must understand um, the basics of thyroid hormone synthesis. So we know that iodine is essential for the thyroid hormone synthesis. So iodine is uptake. So iodine uptake here, the iodine is taken along with the sodium. There is a sodium iodide symporter is here. So this is the thyroid follicle, and this is entrapped inside the iodine is trapped by the follicular cell, and it is finally transported to where here is the colloid. Here is the colloid. So the iodine is transported. Here is one protein for the transport of iodine that is known as pendrin. Pendrin. Have you heard about a syndrome called Pendred syndrome? Pendred syndrome. So it is associated with a mutation of gene coding for this protein pendrin. So what are the features? One is bilateral sensory neural. So this is also present in the cochlea. Sensory neural hearing loss. And the other one is the goiter. So Pendred syndrome. So pendrin is a transporter which transport chloride and the iodide. So this iodide is oxidized by thyroid peroxidase here in the colloid. Thyroid peroxidase. And this iodinization, and this is this. So this is oxidized, and this iodine is combined with the tyrosine. So here one amino acid is synthesized by endoplasmic reticulum and stored in the Golgi body, and it is released as thyroglobulin. This tyrosine combines with iodine to form monoiodotyrosine and diiodotyrosine. This step is known as organification. This organification is affected if we take excess iodide. So it will alter the redox potential, and it will cause the many problems. So this effect is known as Wolff-Chaikoff effect. Excess iodide which affect the organification or combination of tyrosine with iodide. Iodide is known as Wolff-Chaikoff effect. I hope it is clear. Next, we move on to next question. Calcium absorption of the gut is enhanced by which hormone? Parathyroid hormone, calcitonin, 125 dihydroxycalciferol, or all. So the calcium absorption is mainly intestine, the proximal intestine, and it is promoted by one hormone, is dihydrocholecalciferol or vitamin D3 or calcitriol. So calcitriol is the one which helps the absorption of calcium from the intestine. So calcium is absorbed from the proximal intestine. And the parathyroid, what is the role of parathyroid hormone? Parathyroid hormone actually which stimulate the synthesis of 125 dihydrocholecalciferol or increase the absorption. So indirectly, parathyroid hormone stimulate the calcium absorption by stimulating the synthesis of 125 dihydroxycholecalciferol. But the answer here is, the correct answer is 125 dihydroxycholecalciferol, which is the hormone is essential for calcium reabsorption from the intestine. Vitamin D3 or calcitriol. Parathermone has parathermone has the effect has the following effect except the parathermone is the hormone which cause the bone resorption. This is a correct option. And it increases calcium reabsorption from the kidney, from where it acts on the thick ascending loop of Henle and the collecting duct, which will increase the absorption of calcium. So finally, it will increase the blood calcium level. This is the wrong answer. Increase phosphate reabsorption from the kidney. It actually decrease phosphate reabsorption from the proximal convolutory tubule. Decrease reabsorption, and which it also increases the calcitriol synthesis. So the wrong answer here is the phosphate reabsorption. It instead of increase, it decrease phosphate reabsorption from the kidney, from where proximal convolutory tubule. Increase LH. So this is a question from reproductive system. LH secretion. Increase LH secretion. We know that for the ovulation we need LH secretion. That is known as, that we call it as LH surge, is essential for the release of ovum. So this is by the option A, positive feedback by progesterone, option B, positive feedback by estrogen, positive feedback by FSH, negative feedback by estrogen. It's by the positive feedback by estrogen. Positive feedback. The answer is positive. An increase in the level of estrogen which lead to an increased secretion of LH. That is the positive feedback by estrogen. So this is the developing oocyte, which is covered by two types of cells. For the first cell layer, there are so many layers of cells are known as granulosa cells. Granulosa cells, which has FSH receptors on it. So granulosa cell has FSH receptor, and another cell mass around this layer is theca cell layer. Theca cell layer. Theca cell has, which is analogs to Leydig cell in males. The theca cell has LH receptors. It is known as 2 hormone, so this will produce progesterone, but these are the receptors: LH receptors on theca cell, FSH receptor on granulosa cell. So here the LH act on theca cell to produce androgens. Here it produces androgens. This androgens goes to granulosa cell, and granulosa cell which contain an enzyme known as aromatase. Aromatase enzyme which will convert androgen to estrogen. So this estrogen helps the proliferation of follicles. So then what is the role of FSH? When FSH act on FSH receptors of granulosa cell, this will stimulate this enzyme which will convert androgen to estrogen. So FSH stimulate aromatase enzyme and increase the level of estrogen. When the level of estrogen increases, it finally cause any feedback, positive feedback on LH and increase the LH surge. That's the basic mechanism. Here you can see the different pre-ovulatory phase. The level of estrogen level increases from 8th day onwards, and it reaches the peak before ovulation, which coincides with the LH surge. And the post-ovulatory cycle, it is progesterone. Progesterone is secreted by this corpus luteum. FSH receptors are present on, so we have already discussed, it is present on granulosa cells. Which receptor is present on theca cell? LH receptor. Leydig cell, LH receptor. This is this diagram is important. It is a hypothalamus pituitary ovarian axis. So GnRH is released from the hypothalamus, which increases secretion of LH and FSH. LH act on theca cell, FSH act on granulosa cell. And this one is also important. Inhibin B. Inhibin B is another important MCQ. Which cell secrete inhibin B? Granulosa cell, which inhibit FSH release. So inhibin B is another important MCQ. Granulosa cell secrete inhibin which act on FSH receptors. and which act on the anterior pituitary and inhibit release of FSH. Let's see a few questions from the GIT and CVS. Normal AV nodal delay. Normal AV nodal delay is 0.1 second, which is due to decreased amplitude of firing, resistance offered by myocytes, decreased number of gap junctions, lack of tight junctions. So AV nodal delay, there is a delay of 0.1 second in the AV node. So it gives enough time for contraction of ventricles. So after completing the contraction of the atria, there is a delay to start the contraction of ventricle, which helps the enough filling of the ventricle. So there is a 0.1 second. So there are many reasons. The most important is decreased number of gap junctions. So AV node is considered as the gatekeeper of heart, which shows a slow rate of conduction. The reason for AV nodal delay, because which contains small cells arranged perpendicular to the current. So the AV node contains very small cells, so resistance is more. Very less gap junctions. So the impulses are communicated through these gap junctions, very less gap junctions, which shows more resistance. These cells are perpendicular to the current. These are the reasons for AV nodal delay. This the table showing conducting velocity. So the minimum conducting velocity SA node and AV node, and the maximum for Purkinje fibers 4 meter per second. 4 meter per second. Plateau phase of ventricular muscle is due to. So this is an action potential of ventricular muscle. Here is an action potential. When we draw an action potential, there is a plateau phase. The phase 2 of phase 2. This is 0, 1, 2, 3, 4. There are 5 phases. This phase 1, phase 0 is an increased, a fast depolarization. So the resting membrane potential is minus 90 for the cardiac muscle. So here is a phase 0, it's the influx of sodium. Here is phase 1, so there is a rapid depolarization, and here is a phase 1 is potassium efflux. Then it comes back to and this potential decreases. Here is a phase 2. Phase 2 is due to calcium influx, opening of calcium channels. Calcium ions are moving into the cell. Potassium are moving out. So it both two are cancelled out. So it shows a plateau phase. The plateau phase is the responsible for absolute refractory period of the cardiac muscle. And this is the fast response potential. And one more potential is seen in the cardiac muscle. It is the pacemaker potential. The pacemaker potential is here. Is the pacemaker. This portion is the pacemaker potential. This potential is due to a change. Actually, it is not a resting membrane potential. It is a restless type of membrane potential. It always changes from minus. The resting membrane potential changes from minus 60 to minus 55. Minus 55. This potential is due to a certain type of channels. These channels are known as funny channels. Funny channels through which the sodium and potassium can enter. Mainly sodium enter through this channel. So the main reason for this resting this potential, this potential is due to the pacemaker potential is due to sodium entry through this funny channel. Or another reason is decreased potassium permeability. That is known as potassium decay. This is another reason. Decay, that is potassium decay. This is also correct. Decreased potassium permeability or potassium decay. But the fast sodium channels is also correct. Pacemaker potentials through the funny funny channels. Sodium entry also correct. Sodium entry through the funny channels is one reason. Another reason is decreased potassium permeability, that is known as potassium decay. Next question from GIT, which is the pacemaker of GIT? Everyone knows the answer. It is the interstitial cells of Kajal. Interstitial cells of Kajal. It is mainly in the duodenal region. The basal electrical rhythm is originated from this pacemaker cell. Migratory motor complex or migrating motor complex. Migrating motor complex is occurs. Option A occurs upon the arrival of food in the stomach, begin the lower part of the small intestine, are initiated by the pacemaker cells of intestine, occurs at a rate of 5 centimeter per minute of the stomach. So here the correct answer is occurs at a rate of 5 centimeters. So last option is the correct one. So about the migratory motor complex, they are seen in the, it is a the movement, or it is seen in the fasting state. This motility is the migratory motor complex start in the stomach and also in the intestine, to clean the intestine, to remove the extra food from the stomach and intestine before the next meal. So it is known as the housekeeper of the GIT, housekeeper of GIT, and it is initiated by a hormone known as motilin. All these are important, and its rate is 5 centimeter per minute. Migratory motor complex. So which of the following statement regarding secretin is least correct? Secretin is increased bicarbonate-rich secretion is correct. It inhibits gastric secretion is also correct. So it actually increases the pancreatic secretion, bicarbonated watery pancreatic secretion, but the gastric secretion is inhibitory. And it increases the gastric acid secretion is the wrong option. It causes contraction of the pyloric sphincter. It also causes the contraction of pyloric sphincter. So secretion is about secretin. It is a hormone first hormone identified Baylis and Starling. Source is S cells. And the physiological effects, it increases the bicarbonate secretion and watery alkaline pancreatic secretion. It augments the action of CCK. It inhibits the gastric acid secretion. So it inhibits gastric acid secretion. It increases the pancreatic secretion and increase contraction of pyloric sphincter. So actually now it's about 9 o'clock. So I will share the slides. We had to discuss these topics also, but because of time constraints, we are not in a position to discuss the general physiology, nerve and muscle physiology. I will share the slides to you.